Good morning. Good morning, everybody, and thank you so much for joining our Health Partners Women's Health Coffee and Chat, navigating perimenopause and menopause. Before we get started, a few housekeeping items. Please send your questions to our speakers using the Q&A tool at the top of your screen, and we will address as many as possible at the end of the session. Please do not ask any personal medical questions. And finally, this session is being recorded and a link will be sent to you after the session. Thank you. Just a bit on, I would like to introduce our presenter today, Dr. Sari Witzke. Dr. Witzke is a board-certified obstetrician and gynecologist with HealthPartners and Park Nicollet Women's Center. She earned her medical degree from the University of Minnesota Medical School and completed her residency in obstetrics and gynecology through the University of Minnesota. Dr. Witzke cares for women across all stages of life, from adolescence through menopause, and is passionate about building long-term relationships with her patients and providing personalized, compassionate care. Her clinical interests include women's health, menopause, menstrual disorders, obstetrical care, and adolescent gynecology. She has been recognized as a Minnesota Monthly top doctor and is dedicated to helping women make informed decisions and thrive through every life stage. Thank you so much to Dr. Witzke for spending time with us and sharing all of your expertise on menopause this morning. And with that, I will send it off to you. Thank you.
All right, thank you. Good morning, everybody, and thank you for spending some of your morning hearing about perimenopause and menopause. It is an issue that is very deep in my heart and something that I'm spending a lot of my career doing at this point in time. I thought I would start out by just doing a few definitions so that we're all on the same page getting started with this talk. Perimenopause is a several-year period leading up to a woman's final menstrual period. It can be hallmarked by some menstrual irregularities, the beginning of some menopausal and perimenopausal type symptoms, and perimenopause ends 1 year from the date of your final menstrual period, which is the date that you enter menopause. Menopause actually only lasts 1 day of your life, and once you are 1 day into that, you become postmenopausal for the remainder of your life. Some women have menopause happen gradually, and others have it be surgical or induced menopause, which would happen after removal of both of your ovaries at the time of surgery or damage to your ovaries from chemotherapy or radiation. Okay, next slide. There are many symptoms that can be associated with perimenopause and menopause. I have several of them listed here. There are definitely some that didn't make this list, and each day when I'm in clinic, a patient will come up with a new one that I'm not sure is related to perimenopause or menopause, but then I hear it over and over, and it must be. So I have the symptoms highlighted here. When you look at this list, it seems a little bit daunting, and it seems like this could be a really difficult stage of life. But that's what we're here for. We're here to help mitigate some of these symptoms and make this stage of life one where women really thrive. Okay, next slide. This is what I find so interesting about care for women in perimenopause and menopause is that individualized care is really important. We really have to look at the whole woman when we care for these patients. We look at their medical history. We look at their family history, especially for things like cardiac disease and heart attacks. We look at our patients' cardiac risk factors, including their family history, including their current cholesterol level. I'm starting to check a lot of lipoprotein A's and getting sometimes some coronary calcium artery scores to decide their risk benefit for starting hormone therapy. We also see a lot of patients that have had different types of cancers, especially breast cancer patients, and we take that into account when we determine the correct therapies for them. Okay, next slide. There are many treatment options available for perimenopause and menopause, and I'm not going to give you a thorough consultation with this talk, but A lot of times we will use birth control pills or oral contraceptive pills, especially in women in perimenopause. This is a common regimen, especially for women that still need contraception and they're not quite menopausal yet. I am doing a lot of hormone replacement therapy in my practice, which can involve estrogen therapy. Estrogen is available in a patch form, which has been real interesting lately because there's a nationwide shortage of estrogen patches. It is available in a gel form. It is available in an oral form. It is available in a vaginal ring. There are lots of options for estrogen. We also are using a lot of progesterone. Oral micronized progesterone is probably the most common progesterone I use in perimenopause and menopause. I'm also using a progesterone-only oral contraceptive called Slind really commonly in my practice, again, especially for women that are still requiring contraception. There's also some synthetic progestins that are the best choice for some women, especially women that are having a lot of bleeding on our traditional regimens. So those are all common options. Some of our providers at HealthPartners and Park Nicollet are prescribing testosterone therapy. I would say that most of us that are menopause certified are doing this therapy. Definitely not all providers are comfortable with this, but it's definitely something that we can have a conversation about the pros and cons of that therapy in perimenopause and menopause. And vaginal therapies are also very common. There's a condition known as the genital urinary syndrome of menopause, which comes more as women get in menopausal and beyond. And that can consist of vaginal dryness, frequent UTIs, painful intercourse. So I am prescribing a lot of vaginal estrogen products, which comes in a few different formulations, or vaginal DHEA. There are also alternative options available for women that are either not a candidate for hormones or don't want to take hormones. We use SSRIs, which are antidepressants like Zoloft, Lexapro, and those can really help with some of the vasomotor symptoms of menopause, especially for women that are having mood symptoms as well in their menopausal journey. Veoza, and there's another one called Linkette, which are neurokinin receptor antagonists, which have really been game changers for women with breast cancer. Women with breast cancer are not candidates for traditional hormone replacement therapy. And those women, a lot of them end up having loss of their ovaries for chemotherapy or are on medication to suppress their ovaries. So they are in real abrupt menopause at young ages. And in the past, they'd really been told that that's just part of the deal with the treatments that they're on to save their lives. But these new neurokinin receptor antagonists really can be helpful for women with breast cancer to reduce their vasomotor symptoms. I would say they're life-changing for these patients. And gabapentin is another therapy that is sometimes used for vasomotor symptoms in women that can't take hormone therapy. Okay, next slide. In addition to therapeutic options, such as prescription therapies to thrive in menopause, I really discuss with my patients that you also have to really make lifestyle a priority. You need to make sleep a priority, you need to get regular exercise, and you need to focus on your nutrition to thrive in menopause. Next slide. So this slide talks about sleeping. You really want to keep your bedroom at a cool temperature, 65 degrees as possible, which has been real tough the last few weeks with these 95-degree temperatures. You want your room dark. You want it to be quiet. You don't want to eat before you go to bed. And you want to have a really peaceful bedtime routine. You want to try to stay off your phones and devices or watching TV for at least 30 minutes to an hour before you go to bed. I find that my patients in perimenopause and menopause really try to make sleep a priority, and they feel much better. Next slide. Also, exercise. Moving your body is really important as we change into these perimenopause and menopausal stages of life. I really talk to my patients a lot about strength training. Some of my patients have never lifted a weight in their life. And in menopause, you can lose muscle mass, you can lose bone mass. And so strength training is really important as we age. And I give my patients a lot of strategies. I give them some online resources to try to maintain their muscles and bones. Okay, next slide. And fueling your body. I really recommend a Mediterranean whole foods diet. I really recommend making sure they're increasing their protein in their diet and reducing stimulants, especially afternoon. I have a lot of patients in perimenopause and menopause where weight gain is really their main complaint. And so we really try to focus on this. Patients that are really struggling, I'm also happy to refer to some of our weight management doctors or back to their primary care doctors to discuss further weight management strategies. Next slide. I recommend before you see a physician for perimenopause and menopause care that you keep a journal. Pay attention for the month or two that you're waiting for your appointment and track how your periods have changed, because these are questions that your doctor is going to ask you when he or she sees you. We'd like to know how your cycles have changed. I really like to know what symptoms you're experiencing. In my practice, my nurse gives my patients, when she rooms them, a symptom checklist. And it's how much things are bothering you. There's 3 categories. I actually have this checklist in a later slide. And that really helps me to focus on the top few symptoms that patients are experiencing so that we can try to get at those. How long have you noticed the symptoms? How severe are they? And how have they changed in the past 3, 6, or 12 months? This is all information that can be helpful for your clinician as we move forward. Okay, next slide. And again, here's some tips for talking to your doctor, sharing the journal that we just discussed, listing your top 3 most bothersome symptoms. That's really helpful for me to know what we're working with. Especially if you're a new patient to our organization, I would love for you to bring a list of your current medications, vitamins, and what supplements you're taking. I'd also love for you to know your personal and family health history. It's a good time to touch base with your parents, your siblings before you come in so that we know what things we need to think about. Be honest with your provider about your lifestyle, about your alcohol intake, smoking, things like that also play into our therapies. I like to know if patients have specific preferences when they come in about what they're hoping to gain, what treatment options they're hoping to gain during our visit. Take notes, ask questions. You will get an after visit summary after we see you. And some of the care with perimenopause and menopause, I wouldn't say is trial and error, but we do have to sometimes do some dose adjustments and some treatment adjustments to find the right regimen for patients. So you need to be patient and commit to the process. And find a doctor who listens to you and is comfortable with this stage of life. There's lots of us available in our organization that are doing this care and are happy to take care of you. Okay, next slide. So menopause is truly having a moment in our society right now. There have been a lot of headlines about menopause, between the black box warning being removed for some estrogen products, and there's been some legislation around menopause. And if you are at anywhere a woman between 35 and 65, or maybe even a broader range, your social media feed may be full of menopause content. I know mine sure is. And there are a lot of menopause influencers out there. There are some prominent OBGYNs, there's some prominent urologists, there are a lot of life coaches, there are a lot of lay people that have a lot to say about menopause. There are people everywhere willing to sell you an exercise plan, willing to sell you supplements to try to make this stage of life easier. And overall, I think that is good for women. I think women are feeling like they can seek care in this area of their health and their life. And so I really do think it's given women license to talk about this. I know it's a conversation at my book clubs, and all of these different phases of life. It is really a hot topic. All right, next slide. There are a lot of providers getting in on this menopause movement. Obviously, all of the health systems are having providers that take care of menopause. There are also medi-spas. There are online menopause practices. There are people doing pellet therapy for menopause. And so really finding evidence-based care can be challenging. So we are really committed here at Park Nicollet and HealthPartners to provide evidence-based care and to follow current guidelines on menopause care. And I think it's a time of life where women can feel really out of sorts and feel really desperate to feel more like themselves and better. And so I really am hoping that we can continue to grow our practice here and provide good evidence-based care for women through perimenopause and menopause. Okay, Next slide. The demand for menopause care throughout our organization is just going to continue to grow as more women age and enter this phase of life. The thing that I'm noticing as well, doing this as a large part of my practice, is that we are getting patients from outside of our organization that are new to us, that saw OBGYNs elsewhere in town, that are coming for our menopause and perimenopause care. Once I signed up to be in the Menopause Society, I got all kinds of new patients coming that got my name off of the website. So it really is a great opportunity for us to recruit new patients to our organization. Okay, next slide. We have many providers on our team who are specialized and interested in providing this care. We have 83 providers who list or mention menopause as a special interest in their practice. It has been a little bit of a challenge through our clinician biographies to get all of this information updated, but we're working on that. We have several providers who are Menopause Society certified practitioners, and I will get to what that is in a minute on a future slide. But we're working on making sure that everybody knows who is comfortable providing this care. I've also had a lot of primary care doctors reach out to me that their patients are asking for this care and they want to learn more. So we're working on kind of doing some program developments to get everybody up to speed and comfortable providing this care to their patients. Next slide. The number of women with moderate to severe symptoms who could benefit from our expertise, again, likely exceeds the capacity that we have in place today. So this is just a slide that reiterates that, and I'm hopeful that we can get more providers up and running and comfortable providing this care. Next slide. Our organization surveyed many of us, and there is definitely strong interest in providing menopause care. Menopause care takes time, and I think some of the messages that came through with the survey is that it helps to have some of this care standardized, have more education available for our clinicians. This takes longer times. You can't do a menopause consultation in a 15-minute visit. So we need 30, even sometimes 40, 45 minutes to really be able to care and provide this individualized care for our patients. And we need multidisciplinary support. I feel like our organization is really well set up with this because we have all of these specialties available at the touch of our fingers to be able to consult when we have questions about underlying health issues, etc. So our biggest opportunity isn't recruiting more interested physicians, but it's creating a sustainable system for us to provide high quality menopause care without burning out. All right, next slide. On the right side of the slide, it lists the people in our organization that are currently Menopause Society certified. We have 8 OBGYN providers on the Park Nicollet side. There are 2 on the HealthPartners side, and we have 5 clinicians in primary care that also hold this certification. One thing that we're doing that I'm finding really helpful is that we have a Teams menopause care chat. And there are, I believe, 45 or 48 clinicians that are on this Teams chat now. And we, with outpatient identifiers, will put questions out to the group that are clinical conundrums. Like, do you think that it's safe to give this patient transdermal estrogen? And it is really a really collaborative group. There's primary care, there's OBGYN, and I feel like we get really good, comprehensive questions answered. I put questions on there, I answer questions on there, and it's really a great way for us to collaborate. Okay, next slide. So what is a Menopause Society certified practitioner or a menopause specialist? The Menopause Society is kind of our overall overarching group, like ACOG is for OBGYNs, the Menopause Society is for menopause. And so in order to gain this certification, you do need to join as a member of the Menopause Society. There is about a 200-page dense textbook which is put out by the Menopause Society, that really, it talks a lot about hormone therapy, but it also really just focuses on care of women in midlife. It talks a lot about bone density, about osteoporosis, about cardiovascular disease. It's a comprehensive textbook regarding care of midlife women, and I found it really helpful to read. Then you need to pass a 100-question proctored exam. And in addition to maintaining your CME to maintain your medical license, you also need to get 45 hours of continuing medical education every 3 years. I believe 15 hours of that needs to be in menopause. So by my calculations, I need to attend the Menopause Society annual meeting about every other year to maintain my certification. When to seek a consultation with one of us that's a menopause certified practitioner, I would say when your primary care provider, OBGYN, isn't feeling comfortable with whatever part of your care or isn't comfortable providing this care, or if you have medical conditions that require more expertise. For example, cardiovascular disease, breast cancer. I see a lot of complicated patients that we really need to think through and find the right answer. And I sometimes do reach out to my cardiologist colleagues, my oncology colleagues, to make sure that we're taking the best care of these patients. Okay, next slide. These are some of the resources that we have created through our menopause work group. On the left side of the screen, you can see a menopause questionnaire. I believe it is two-sided. You can see one side here, but it really gets to the crux of the things that I want to know about the patient, her habits, her menstrual history, her personal information. On the back, it has her family history. Then the middle of the slide is the symptom checklist that I was referring to. And patients can do this in about 2 minutes, and it's really helpful for me. I really focus on, on the right side, which is the symptoms that are bothering them the most, and we kind of start there. And on the right is just a comprehensive handout for patients on menopause and hormone therapy that's available on our website. Okay, next slide. On the right here is this menopause guidebook that is put out by the Menopause Society. And it is about a 50-page book. It's really well done. That gives really good evidence-based information about menopause and caring for yourself in this phase of life. When patients have a menopause consultation with one of our menopause certified providers, we are handing out this book at the end of the visit. Patients are thrilled. They cannot believe that they're walking out of the visit with a 50-page resource. And these patients are interested, they're reading, and they really appreciate this gesture. Next slide. So this slide just talks about our menopause resource group and the Teams chat that I referred to earlier. Okay, next slide. Here are some of the plans of what we have planned in our organization to improve care over the next short-term and long-term for our menopausal patients. In the short term, we're looking at developing a menopause smart set, so different medications, different dosages, just to make sure that everybody that wants to learn this care has that at their fingertips. We're working on standardizing the consult visit types and, again, aligning that with the correct period of time. We are expanding our clinician resource group with monthly expert education sessions. I envision this as having our group get together once a month and maybe bringing in specialists, from bone density specialists to cardiology to sexual health, and really having them give us a talk so that we can best care for our patients once a month. We're working on these patient education materials and the pre-visit questionnaires, which is what I kind of alluded to a few slides back. And we're launching a menopause colleague resource group. What's coming in the future is building some clinical pathways, offering support for more of our providers to become Menopause Society certified practitioners and support that work, to launch some multidisciplinary care conferences, and to pilot menopause-focused e-consults so that patients can consult one of us with quick questions on an e-consult. Long-term, I would love to create a menopause center of excellence here at Park Nicollet. I think we are the perfect organization to do it. When I was at the ACOG menopause meeting last year, UCLA has something like this that we've been really looking at, where they offer collaborations from all the different specialties involved in caring for menopausal women. Next slide. I think that would be amazing. And this is all the specialties that I think can be involved in caring for women in midlife. Rheumatology, primary care, myself in OBGYN, behavioral health, pelvic floor physical therapy, sexual health, sleep medicine, urogynecology, our breast center colleagues, oncology goes along with that. Cardiology we utilize a lot, neurology for patients that have migraines and dementia risk, dermatology, acupuncture, and obesity medicine. Rheumatology also for bone density concerns. So I really feel like this is truly multidisciplinary care required for these patients. And I think it makes patients feel good when they know that we are looking at their whole health course. Okay, next slide. All right, impact through philanthropy. What support could we use to help better maintain our menopause practices?
Thank you so much, Dr. Witzke. That was fantastic. And I would just like to introduce Pete McNabb, our grants program manager, to speak on the impact through philanthropy and how we have supported women's health across the system.
Hi, thanks, Ivy, and thank you so much, Dr. Witzke, for your fabulous presentation. I was really thinking back to when I started at Park Nicollet Foundation, and one of the first things I saw when I started coming on site to Methodist Hospital was the Women's Center. And it was explained to me early and often how important women's health is, not just to Park Nicollet, but to the foundation, and the history between philanthropic support and the Women's Center and women's services in general is just so robust and special to us. And I think too that as we go forward and discuss some of the opportunities and past wins that we've had with philanthropy and women's health, I think that for me, the way Women's Services and Women's Center represent our system's attitude towards care as a whole feels really indicative and important, right? And we just saw that wheel of different, services and disciplines that are all made up in the whole of somebody's life and in women's health. And that interdisciplinary approach feels just like very much to be patient-centered care, which is what we love and try and provide for here. So, at HealthPartners, we believe, at the foundations too, that when women are healthy, our entire community thrives. And so, in whatever way the foundation can provide support for that, and for women at every stage in their life, from pregnancy and delivery all the way through menopause, we want to solve for that whenever possible. So I think, Ivy, we can advance probably a couple slides in the next one. So I mentioned the Women's Center at Park and Methodist, but that's just one example of the care that's, we're providing for everywhere at HealthPartners. So to harken back to some things that we heard earlier, just about access to menopause specific care, we heard a lot about the desire to train, educate, and bring more clinicians and disciplines up to speed with what our menopausal patients are needing and wanting from their providers. And we think that philanthropy can play a role in raising funds and to trying to make education for these services, for this expertise, more and more widespread and available to Park and HealthPartners providers. So that is kind of a top of mind opportunity that we see and would like to lean into, with our community's help to make this care more available at HealthPartners. You can go on to the next slide. So I mentioned too about the spectrum, and we just want to make brief mention of that again here, that the great thing about women's services at HealthPartners is that it is the full spectrum of care. And Healthy Beginnings is one of those community programs that we're really proud of, which we feel helps to support that margin between what we can do on the level of providing healthcare and what the other social and community influencing factors are are that make up the whole person and make up care itself and health outcomes, really. So this program has been around for 35 years. You've probably heard of it, but we want to remind you that making sure new families have a healthy beginning, quite literally, that have the resources and sustenance, food, diapers, car seats, all those kind of basic amenities that children and families and mothers need to feel strong and secure and tethered to this new life that is starting in this beginning that's happening. So this is a continuous program. We raise funds for this through the One campaign, but it is ongoing, always present in our clinics and amongst our patients. So next slide. Relating once more back to labor and delivery and healthy beginnings, we want to make sure that the spaces in which our patients receive care are comfortable places to receive care. And so we've accessed and used philanthropy and raised funds for making sure that furniture is up to date, that we can provide for new fetal monitoring recliners, just to make sure that our clinics and the places where patients are being seen and cared for and helped on their journey are nice to be in. We think that's important, and that is a part of making sure health outcomes are ones that satisfy our patients' needs and promote longevity and wellness. So labor and delivery, always looking to raise more money and to provide for better access and better facilities. And it takes a lot to keep these up to date. So looking forward to more of that. And then once more, flip the slide. All right, and the last thing I want to just mention is that innovation is a huge part of women's services at HealthPartners and of all our service lines. And recently, we've done some grant work with them to provide for gynecologic surgery innovation. The tools that are available to us are always changing and being enhanced. It's hard to keep up with, but we try to do as much as we can. Recently, some implements were bought by our gynecology department with support from the Park Nicollet Foundation to improve surgical visualization during some of these procedures, helping to reduce time in surgery, which is huge, especially supporting patients in and during anesthesia, reducing the amount of time that they're under, and then increasing all these operating room efficiencies, allowing for providers to be redeployed to patient care. If we can have less providers are needed for one task, one surgery, one procedure, then that just opens up access elsewhere, because we know access is and continues to be an issue, and we want to make sure that people and women can be seen early and often for whatever health needs are rising to the occasion. So we're always looking to invest more into surgical innovation, facilities, surgery, capital, healthy beginnings, all of these aspects. There's another wheel mirroring the one that Dr. Witzke was showing, and those are the philanthropic supports that can help provide for all those aspects of patient care and women's health. And we've had a little bit to do with all of it, and we want to have more to do with much of it. So thanks again for letting me chat a little bit with you about some of the philanthropy, and thanks again for Dr. Witzke for her time today. So.
Thank you so much, Pete. We have one of the most active Q&A sections I've ever seen. So clearly this is very important to a lot of people, and is such an important topic. So before that, we won't get to all of these questions, but I wanted to highlight a note that Lisa Black put in the chat or in the Q&A. She says, we also have a Teams chat for employees as a resource group. Please join if you would like. So I'm going to just pop that into this chat, which has a link.
Great.
So for any questions that aren't, going to be asked here, feel free to join that. But so first off, we have a question about the preferred method of weight training. Is yoga a good source of weight training? Or what are the pros and cons between isometric exercise versus actually weight-bearing exercise?
Yep. I think yoga is a great form of exercise for women in this stage of life. I definitely think it has a strength component to it. But I also think that as we're working on maintaining our muscle and our bone mass, you do actually have to be lifting some weights and having that load on our muscles. So I think, you don't want to lift weights every day. So I think, if you strength train 3 times a week and add yoga in another once a week, if you can, and then again, we all can do what we can do, but I think that the two complement each other.
Great, that's fantastic. Next question is, are there assessments that can be done to differentiate between the quote unquote menopause brain and early signs of dementia-related diseases?
That's a really good question. And, most of the patients that I'm seeing are kind of in their early 40s to their mid 60s. And so a lot of times what we'll do in perimenopause and menopause care is do a trial of hormone therapy and see if it resolves their symptoms. And if they're still having a lot of cognitive symptoms, and I would go ahead and refer them on to neurology, or at least to their primary care doctor to pursue evaluation of that.
Okay, wonderful. And then we're wondering about resources that cover menopause. So you mentioned the guidebook, and then we're wondering if there are other resources you would feel comfortable recommending.
There are a lot of good books out there. Mary Claire Haver is a controversial OBGYN, but I actually think her books are pretty reasonable as far as menopause information. I think the Menopause Society has some really good resources on their website if you go to their website. And Jen Gunter has a book called The Menopause Manifesto. That is also a really good evidence-based resource for women looking for more information on menopause. Those are some of the top ones that I will recommend.
Okay, wonderful. After you actually reach postmenopause, can you expect some of these symptoms to reverse themselves, or are we in a new normal?
That's a great question. In my experience, I think there's kind of an early phase of perimenopause and a late phase of perimenopause. And the late phase of perimenopause periods start to space out sometimes to 30 to 60 or 90 days. I find that is actually the time when women get the most symptoms. Now, some women don't get any symptoms as they go through this menopause transition, but I think that late perimenopause and then the first few years after the final menstrual period is when women have the most symptoms, as far as especially hot flashes, night sweats, the vasomotor symptoms, those kind of things. And those do tend to taper off as you get later in life. Most women do not continue to have hot flashes and night sweats into their 80s.
That's great news.
Mm-hmm.
And then if periods are suppressed due to being on an IUD, how would women know if they're having menstrual changes?
That's a really good question. So I tell patients all the time that I typically don't do a lab evaluation on everybody to figure out if they're in menopause, because in perimenopause and early menopause, our hormone levels are really fluctuating. So it's hard to know exactly where you're at. The exception for that for me is women that have IUDs, and especially women that have had long-term IUDs. So we do not know where they are in their menstrual process. And you can check estrogen and FSH levels in women that have a progesterone IUD, which is a Mirena or a Kylena. So I will check lab values in those patients to kind of figure out where they're at. Also, because a big piece of the puzzle for a lot of these women is do they continue to need contraception? And at what point do they not need contraception? So we will do lab values in those instances.
Fantastic. Thank you so much.
Mm-hmm.
And then one question about the book that you recommended. They said, I have also searched for the Menopause book by ACOG. This book is not coming up on the internet. Is this only for providers, or is there another similar book we could buy online?
ACOG does have a menopause book. I actually have it sitting on my bedside table right now. I haven't read it yet, but it's on my list of things to read. And I typically don't love to recommend things until I've read them. But ACOG publications are typically really good. So is it available on the ACOG website? I'd have to look to see where it's available.
Yeah, maybe we can
We might be able
try
to
and
do a
find a
follow-up
link.
on that. It might even be available on Amazon. I can't,
Yeah.
I apologize. I don't remember where I got it, but I literally have it sitting on my bedside table.
Oh,
So it
that's
exists. Yes.
well, if you're comfortable recommending it, we can provide a
I
follow-up
mean,
link
ACOG
in the
resources are usually well vetted.
yeah,
And so I haven't read that one yet, but I would be comfortable recommending it.
fantastic. And then one other question, and this is rapid fire, but thank you so much for answering
That's
all
okay.
these. But can you explain how gabapentin is used in postmenopause?
Yep. So I don't use gabapentin a whole lot, but gabapentin is another alternative. It wouldn't be my first line agent, but for women that are not a candidate for hormone therapy for a medical reason, gabapentin can sometimes help with vasomotor symptoms of menopause. So we use it in women that are having hot flashes, night sweats that are not candidates for other therapies.
Okay. Thank you. I just want to shift gears a little bit for a final question to ask what is a key way that philanthropy could support the work that you and your colleagues do to provide care for women in need?
Yeah, I think a big way that philanthropy could help us is that those of us that have gone on to get the menopause certification, it is expensive to maintain menopause certification or regular OBGYN certification, or I'm assuming primary care certifications as well, and to do the CME that you need for your job and also for your menopause certification. So for some of us, we can run out of CME money to maintain all of our certifications. So if there was something available for clinicians to be able to maintain these certifications, I think that would be great. I also think it would be helpful in order to give resources like the books that I talked about to our patients. Obviously, that's not something that's covered by their health insurance, but it's something that our organization has committed to. And so I think, being able to give resources to patients is great.
Those are fantastic ideas. I love that, and I know Pete McNabb is still listening, so we'll
Perfect.
see how that can be. Yeah, if that is an alignment. So that sounds
Mhm.
wonderful. I think that's all the time we have for questions. I just want to shout out that employee resource group for any employees who are on the chat
Mhm.
here to consult and get their questions answered and learn more. But thank you so much to Dr. Witzke for your time, your expertise. We really appreciate it. And we will send the follow-up reporting in a few days and any resources to follow up.
Perfect. It's been my pleasure.
Thank you so much. Bye, everyone.